Okay, and to complete our talk on acute kidney injury organized by Y, we're going to focus on intrinsic renal disease. So in thinking about intrinsic renal disease, I like to organize it based on the three sort of compartments or structures in the kidney. So remember, there's the glomeruli, there's tubules, and then the interstitium, which is the tissue, cells and connective tissue in between everything else. So there can be glomerular damage, tubular damage, and interstitial damage, and we're going to go through each one individually. So here's a cross-section of a normal glomerulus, and it's kind of a complex structure. And just to orient you, remember it's a tuft of capillaries wrapped in podocytes, and it's all held together by some glue. So essentially what we're looking at here are capillary loops, and these are red blood cells, so that tells you it's a capillary. This is endothelial cell, and then the capillary tufts are all held together by these mesangial cells, sort of in the middle of everything else. Okay. On the outside of the capillary loops is a layer of basement membrane, which is here in purple, and then sitting on top of the basement membrane are these podocytes. So the podocytes have foot processes that interlock and have a slit diaphragm in between them, and they form the filter of the kidney, essentially. So this complex structure can be injured in a myriad of ways, and that can result in acute kidney injury. So one category of diseases are diseases that cause glomerulonephritis, and this is sort of a simplified diagram showing the variety of ways glomerulonephritis can occur. And so I like to think about, the itis piece. Nephritis tells me that there's inflammation happening in the glomerulus. So inflammation in the capillary loops or in the mesangium. And so this can occur a number of ways. So down here, you can see that there are neutrophils here in the capillary loops. You can see that this process is driven by immune globulins. So antibodies that fixate complement can cause inflammation in the capillary loops. So, immune complexes in the setting of lupus nephritis is common, and then immune complexes directed against the basement membrane in anti-GBM disease is another example. Also, some of these processes can obviously involve the mesangium, okay? And then you can also have a process that causes inflammation and vasculitis, essentially, but in the absence of immune globulins, and like ANCA-associated vasculitides can do this as well. And then some diseases cause essentially a thrombotic microangiopathy in the glomerular capillaries, and so this is a thrombus. This is a clot, essentially. And so diseases like TTP, HUS can cause a thrombotic microangiopathy that essentially causes nephritis. So this is just a brief overview of all the things that can cause acute kidney injury in sort of broad categories. More detail on glomerulonephritis will be covered in a separate video. So in addition to glomerulonephritis, which has lots of inflammation, there are diseases that cause a glomerulopathy. So these diseases tend to cause specific injury and eventual death to the podocytes. So remember, the podocytes are surrounding capillary loops. They're helping provide a filtration barrier through their foot processes. And so, here in blue is a healthy podocyte. Here in pink are these unhealthy podocytes, which are undergoing some sort of injury and eventual death, as they can eventually peel off and end up in the urine. But when they're sick, they sort of flatten out the foot processes. They lose this nice structure that the healthy one has. And as you lose structure there, it results in significant albuminuria or proteinuria. And so diseases that cause a glomerulopathy, like diabetic kidney disease, for instance, also has vascular changes and mesangial changes, but can also affect podocytes. Diseases like membranous nephropathy or HIV-associated nephropathy all cause some form of glomerulopathy. And eventually, with podocyte death, it leads to glomerular scarring and loss of nephrons and kidney injury. So here are both of these processes eventually lead to nephron loss. Remember, glomerulonephritis is inflammation in the glomerulus. So this isn't good for podocytes. Okay, so if you're hurting podocytes and causing lots of inflammation, sometimes the final common pathway is to cause sclerosis, so scarring down of the glomeruli. And obviously, if you can catch it in time and shut down inflammation, maybe you could stop this process. In addition, those diseases that cause a primary glomerulopathy cause primary podocyte injury and death, which again leads to glomerulosclerosis and tubular atrophy. So whenever you're working up your patient for acute kidney injury, you should get a urinalysis. We can learn a lot from the urinalysis, and many diseases that have intrinsic renal damage can show up in different patterns of the urinalysis based on different markers, and this is highly instructive, and it's relatively easy to obtain and relatively inexpensive to look at the urinalysis. So let's go through a few of these with regards to the glomerulus. So first of all, remember that when we as nephrologists are working up a patient, we do a couple things. One is a dipstick urinalysis, and another is urine microscopy, where we spin the urine and look at it ourselves. And both are indicated because they both give you a lot of information. But let's consider nephritis. So remember, this is inflammation in the glomerulus. On the urine dipstick, you'll see white blood cells. Like, it will stain for white blood cells. It will stain for protein, typically. Remember, the dipstick on a urinalysis is actually staining for albumin, which is something we care about, and it may stain for red blood cells. The dipstick reagent is actually staining for heme pigment. But it's also important to do a urine microscopy, so you can visualize these things. For instance, you may visualize the white blood cells indicating inflammation. You can't visualize the protein, but you can measure it. So you can measure a spot albumin to creatinine ratio. And so a patient with acute nephritis tends to have a good amount of albuminuria. It could be, 1 gram or less, or it could be above 3 grams in the nephrotic range. It's quite variable. Obviously, some diseases that cause nephritis are milder, maybe something that's more chronic and smoldering, like IgA nephropathy, may not have albuminuria at the beginning. It may just present with hematuria or red blood cells in the urine. But an acute nephritis tends to cause a good amount of red blood cells or hematuria, albuminuria, and if you get lucky, you may see a red blood cell cast. So if there's extensive inflammation, glomerular damage, capillary leak, and hemorrhage, red blood cells will leak in to the tubules, and what happens, they sort of pack together in sort of a cast of the tubule, and eventually this cast of red blood cells is sort of held together by some protein matrix and is urinated out, and you could catch it in the urine. So if you see this, this is highly specific for glomerulonephritis, because only red blood cells from the glomerulus could do something like this. Okay, what about diseases that come from a nephropathy? Remember, these are diseases that are affecting podocytes specifically. So we like to say this is a bland urine, and that there's no white blood cells, no red blood cells, or if anything, very few red blood cells. But typically you look at the urine and you don't see anything of significance. But on dipstick, there'll be positive proteinuria. But more specifically, if you measure, you will find significant albuminuria. So the best test is a urine albumin to creatinine ratio. And so these patients could have anything from subnephrotic to nephrotic range albuminuria. One thing you may see if you have polarized light microscopy are these things called oval fat bodies. So these are essentially epithelial cells that have engorged on lipoprotein and other filtered proteins, and so they're swollen with protein and lipid, and under polarized light they actually form this interesting Maltese cross pattern. So if you get lucky, you may be able to see this in someone who has significant albuminuria. Okay, next I want to talk about tubular damage as a cause of intrinsic renal disease. One thing to consider is the proximal tubule. So it does a lot of work. It does a lot of work with secreting things as well as reabsorbing all the filtered minerals and water that it wants to keep. And so by reabsorbing everything, it requires a lot of energy. And in order to get that energy, it has so many mitochondria packed into the cells. That's what these little purple things are here to represent. And so because of this high energy requirement, in order to do its job, it's very sensitive to ischemia as well as other toxins. So when there's acute tubular damage, acute tubular necrosis can occur. And so for short, we call this ATN. And so on urine microscopy, what you see is muddy brown casts. This is basically necrotic debris, dead cells that for one moment they were obstructing the tubule and they form this cast, then it eventually comes out in the urine. And so you tend to see sort of a field of debris and discoloration. And then if you look closely, you'll see these sort of cast forms that look like they were in the shape of a tubule. And if you look closely inside the cast, it's like very fine sort of dark brown granular material. So it's smaller than red blood cells or white blood cells, and it's pretty easy to tell the difference. Sometimes it's maybe not as easy, but I think in general, once you've seen enough of them, you can tell that it's made of these really fine, dark granules, and this is characteristic of acute tubular necrosis. So an extraordinarily common reason for acute tubular necrosis is ischemia. And so when thinking about, ischemia, it's a very common reason for hospital-acquired AKI. I want to touch back on some of the other videos we've done. So when talking about global perfusion, we talked about flow equaling the mean arterial pressure minus the renal venous pressure. Well, obviously this can cause, kidney injury up to a point, but if it's prolonged and leads to renal ischemia, that can cause ATN, okay? And also, when considering glomerular filtration, think about all the things that feed into the afferent arteriolar vasoconstriction. If the vasoconstriction is, unopposed and persists, and then there's some other thing that occurs that leads to a low blood pressure or fluid losses, that alone could be enough to make someone go into acute tubular necrosis. So a lot of these things do feed into one another, and so these earlier processes we discussed in other videos can eventually lead to tubular damage and acute tubular necrosis. Now, another mechanism is just direct toxic action of some drug or other thing on the tubule itself, leading to toxic injury that causes essentially acute tubular necrosis. And so one thing to keep in mind is that the proximal tubule is sort of a high traffic area. It's trying to secrete many things and it's reabsorbing things. And many of the drugs we give pass through the kidney, pass through the tubules to be excreted. And if these things accumulate inside the kidney, it can lead to tubular death and injury. And so this is just a representative list of some of the drugs that are known to cause acute tubular necrosis through toxic injury. And so rhabdomyolysis is sort of a subset of heme pigment nephropathy. It causes an obstruction of the lumen, but also there's probably some direct epithelial damage as well. So another way to develop acute tubular necrosis is through infusion of a high osmolar solution. So this is seen with some of the carriers that are associated with IVIG. Sucrose is one of them, and other things like mannitol or starch solutions, which are fortunately not used anymore. But basically, if these substances are passing through the tubule, the proximal tubule will take it up by pinocytosis, so it sort of pinches off a piece of these substances, and inside the cell, because they're hyperosmolar, it can lead to cellular swelling, and if enough of this occurs, it can lead to cell death. So another reason for acute tubular necrosis that you should know about at least.